Hello everyone, this is Amber Floury, and this presentation is on the effects of witnessing the resuscitation of a family member. This presentation is going to cover the effects that witnessing the resuscitation of a family member has on not only the family present, but the nursing staff and the patient as well. The presentation was put together after doing extensive research on evidence-based, peer-reviewed literature that was published within the last 5 years. Of the literature that was found, about 6 articles fit the criteria for this study, and once the articles were reviewed, they showed different attitudes such as positive, negative, and neutral towards family witness resuscitation, and they also showed positive and negative outcomes for not only the family but the patient as well. And then they talked about protocols and educational programs that should be put in place to make sure that family witness resuscitation benefits everyone in the situation. As previously discussed, family witness resuscitation is the focus of the study question for this presentation. The general research area was resuscitation, while the specific research area was the effect of having family present. Now, this is a major part of nursing care because it's important in figuring out whether having family present could be a hindrance to not only the staff's work, but the patient's final outcome. And it could have negative effects on the family witnessing it because this is such a traumatic experience to be a part of. But we also want to figure out if it proves to be beneficial to not only the patient and the staff, but the family present. The Anna Maria College Bachelor of Science in Nursing Program student learning outcome that was met through this presentation was the use of critical reasoning and best current evidence to make nursing practice decisions that support the client's ability to attain, retain, and maintain optimal wellness. The use of critical reasoning and best current evidence portion of the outcome was met by investigating and putting together the best information and evidence from the literature that was reviewed. The nursing practice decisions that support the client's ability to attain, retain, and maintain optimal wellness was met by analyzing the literature to find the most optimal, safe, and effective nursing care to give to the patient and the patient's family in these situations. And it was also met by looking for future protocols and education plans that can be adapted so that everyone can benefit from the situation as well. This is significant to nursing practice because everything is patient-centered, meaning we want to make sure that everything that we do for the patient is going to benefit them. We also want to make sure that having family present is going to benefit the family. This is also significant to nursing practice because having family present could get in the way of nursing staff or medical staff that are there to help the patient, and we want to make sure that this doesn't happen. We could do that by implementing specific policies or educational programs to ensure that everyone understands what's going on and to make sure that everyone knows how to educate family members in the event that this occurs. Now, most people wouldn't think that having family present during the resuscitation process would be a good idea, since witnessing resuscitation can be kind of traumatizing. However, research has shown that having family present can help them in the grieving process because they're able to see that everyone there has done everything that they possibly could for their family member. It's also shown that having family present can leave the patient with a sense of love and a sense of not feeling alone in their last few moments because their family member is there supporting them and being there with them in those last few moments. To respond to the clinical practice problem, articles were searched up on Anna Maria College's database of nursing research and narrowed down to the ones that fit the criteria of the study. The articles were found using a set of key terms on each database. Some of these key terms included family witnessed resuscitation, CPR, resuscitation, and family presence during resuscitation. Now, family was taken in a really broad way, meaning it included spouses, friends, significant others, siblings, parents, etc. These searches excluded articles that weren't peer-reviewed and weren't published within the last 5 years. Of this criteria, 6 different articles were used to construct this presentation after analyzing all of the evidence that was found. For this presentation, the best current evidence was broken up into 3 different categories. The first category was different attitudes, and it was supported by 3 different articles. The first article, written by Raphael, collected a sample of attitudes from nurses in the intensive care unit, the coronary care unit, and the emergency department in teaching hospitals of the Kazvin University of Medical Sciences in Iran in 2017. The sample size was collected by convenience study for a total of 150 nurses. The study findings showed that on average, nurses had a neutral attitude on family witness resuscitation, and this neutral attitude correlated with the self-confidence that nurses had toward family witness resuscitation. The limitations for this article included age, gender, education, years of experiences, employment status, working shift, organizational position, being a member of the CPR team, and a need for continuing education. The second article discussed on this slide was written by Garcia Martinez about the negative and positive effects of family witnessing the resuscitation of other family members. The sample was taken from bibliographic articles between 2008 and 2015. The article included 10 final articles that were synthesized, and they were searched up on PubMed Medline, Lilacs, and Silo databases. The study findings for this article that helped to answer the clinical practice problem found that there were 2 different attitudes on having family present, including negative and positive. The articles did not include pediatric context, since that can be considered a whole other subtopic of family witness resuscitation. Finally, the last article on the slide, written by Jeanette Giba, was on family witness resuscitation and why it should be implemented on units based on different policies. The article wasn't a study design, but it was a journal on how family witness resuscitation can be beneficial and non-beneficial for family and the patient. The article used references that covered studies on family witness resuscitation to gather their own opinion based off the results of those other articles to come up with the conclusion that there was a mutual understanding that family had a positive feeling on family witness resuscitation. The second category for best current evidence is positive outcomes, and there are also 3 articles for this category. The first article, written by Ogsowski, took a sample from a bunch of articles that were filtered through a list of criteria to fit the research design. For adults, 3 randomized controlled trials were found that fit the criteria for the study, and 1 randomized controlled trial was found for pediatric patients. The articles were taken from previously published studies throughout a series of databases, and the study findings showed that in most cases there was a reduced level of anxiety, depression, and PTSD in families who were present for the resuscitation. It also found that there was more of a positive effect on the family rather than on the patient undergoing the resuscitation. The limitations of the research included that it had to be a human study, clinical trial that wasn't duplicated, and that met the inclusion criteria. The second article on this slide, written by Ramakers, took a sample of around 18 articles that came from a larger list of articles that was researched beforehand. The conclusion of the study stated that having family present had a mainly positive outcome. The limitations included a list of terms such as family, family stress, loved ones, spouse, friend, family experiences, resuscitation, witness resuscitation, emergency, as well as arrest. And again here, the term family was used in a wide arrangement of ways, such that it included friends and significant others. The third article on this slide, written by Krokmal, was about family witnessed CPR and it was collected from data from the medical records between 2006 and 2011 in around April. The sample was taken from 323 patients that underwent resuscitation, in which 49 were resuscitated while family was in the room. The study found that families didn't differ in advance directives when witnessing CPR as compared to families that did not witness CPR. The limitations of this study include patients who were 18 years or older, had sufficient documentation in their records, and those who had been resuscitated. The third category for best current evidence was negative outcomes, and this was supported by two different articles. The first article, written by Croakmull, talked about how age was linked to later DNAR orders after resuscitation, and how family witness resuscitation was also connected to a decreased survival of the patient. The second article on this slide, written by Ramakers, proposed that negative outcomes could possibly come from the fact that nurses and doctors today aren't used to having family present during the resuscitation process. For implications for nursing practice, we want to make sure that we have the proper implementation, like facility policies and procedures, to make sure that everything goes smoothly while the family is there. We also want to make sure that we have good educational programs so that everyone understands what's going on and what needs to be done in these situations. For future practice and future nursing research, more research should be done throughout the years to see if hospital implemented policies have helped in setting these regulations and making sure that the best patient-centered outcome occurs. For now, the research that has already been done will allow medical professionals to start working on the best options for their own facilities, on whether they want to use this family witness resuscitation program or not. The research has also been done so far can allow medical professionals to use their best judgment and evidence-based research itself to decide on their own. More research should be done on whether these implemented protocols help in creating the best environment for everyone involved, maybe more of the negative aspects and the family attitudes themselves. The limitations for the articles that were discussed throughout the presentation included patients who had been resuscitated, human studies or clinical trials that were not duplicated, age. In some cases, pediatric patients were used, in some of them they weren't. Gender, education, years of experiences, employment status, working shift, organizational positions, being a member of the CPR team, and need for continuing education, the specific key terms, and sufficient documentation on their medical records. This slide includes all of the resources that were used to put together this presentation. Thank you for listening in.